So I think in the panel we have three medical oncologists, Dr. Chakor, Dr. Kaushal, and Dr. Taha. And there are two surgical oncologists, Dr. Robin and Dr. Priya.
Sir, may I interrupt? Dr. Taha is not there, so Dr. Ashish Singh from Mumbai will be joining us for the panel discussion.
Great. Thank you very much. So welcome to all for this interactive session. Kindly feel free to interrupt because the idea is to have a discussion on early stage lung cancer. So can I have the next slide, please? So this is a 67-year-old gentleman who is a non-smoker who has presented with mild cough, and there is a small lesion seen on a chest X-ray in the left upper lobe, and the CT scan of the chest shows a lesion in the same area. Next slide. Okay, so you can appreciate the nodular lesion in the left upper lobe on the CT scan, and on the PET CT scan, which is lighting up quite well here. And you can't see much in terms of the node in the hilar or in the mediastinal region. Can I have the next slide? So I think this is the summary of the findings there, that there is no metastasis anywhere in the body, and that is the finding of the PET CT scan, that you only see the left upper lobe region with some adjacent pleural tabs. Next slide. So the question to the medical oncologist, to Dr. Chakor maybe. So CT guided biopsy possible, and comments on tissue quantity, which also enables molecular testing. So can Dr. Chakor, so what would be your approach in this patient where the tumor is located in the upper lobe? So how would you, if the patient comes to you, what would be your suggestion or advice to the patient?
So, sir, the first thing will be, yes, CT guided biopsy can be taken, and adequacy of the tissue can be tested at the same time when the biopsy is being taken. And resectability, we can, but it looks resectable, but obviously a surgeon will take the call on that, and definitely they will have to do mediastinal staging to once confirm that the mediastinal disease is not there. But it looks, by the baseline scan, it looks like a very localized disease with no mediastinal nodes at all involved at all.
So my question to the surgeon, Dr. Robin, would be, so would you insist on a pre-surgical testing to confirm that this is malignant disease, or in any case there is a lit up lesion on the PET CT scan, you like to go in for surgery and maybe do the frozen section and proceed? Dr. Robin from Kolkata, is he there? Or Dr. Priya?
Am I audible, sir?
Yeah, Dr. Priya?
So I would definitely ask for a CT guided biopsy. India being a TB endemic country, it is I wouldn't go in without a biopsy for any of the patients unless it's maybe a thymus. So yes, definitely a CT guided biopsy is a must for this patient, sir.
Okay, so I think there seems to be consensus because Dr. Chakor and Dr. Priya feel that we should have a tissue. Dr. Kaushal, you agree to this?
Yes, sir. I agree. And in the quantity of tissue, I want actually at least 3 to 4 cores should be there for the biopsy if possible. And definitely a CT guided biopsy before this thing ascertain the resectability. To confirm the diagnosis, because in India this stage 1 and stage 2 incidence is very less. So first we have to confirm, then only we will proceed for the surgery, I think.
Okay, so I think everybody agrees to this, that we should have a pre-op diagnosis, a confirmed diagnosis of a malignant disease before we go in for a definitive therapy. Next slide, please. No, I think you went backwards. Next slide. So you got the biopsy, which is an adenocarcinoma, and no molecular testing was done on the CT guided sample. Next slide. So, Dr. Priya, please.
Yes, sir.
What would you like to do further to, before you go in for surgery for this early stage non-small cell lung cancer patient who's 67-year-old, fit, non-smoker?
Yeah, okay. So, sir, I would definitely still do a mediastinal staging because unless it's a T1 less than a centimeter, we would prefer to have a confirmed N0. So, yes, I would do a EBUS as well as an MRI brain. We've been actually seeing a lot of patients who are early stage, very small tumors, but they have an oligomet. So, the treatment guidelines and the prognosis of the patient changes completely. So, I would do a EBUS followed by an MRI brain and then proceed for upfront surgery.
All right. So I think Dr. Ashish, you have anything more or different to ask for?
No, sir. I think the negative predictive value of PET is pretty good. So if PET says mediastinum is clear, we can go by that. I mean, the chances of us finding nodes, even on a mediastinoscopy or even surgery, is less. It's only when PET says it's positive, then we are sure only 60 to 70% of time. So I'm pretty certain that this patient has a node negative cancer. I mean, cancer we have not confirmed, but I think on
Cancer we confirmed. It is an adenocarcinoma. We confirmed that.
Right, sir. So then now I think the ball is in the surgeon's court, and patient has to be worked up for fitness for surgery.
Yeah. So the surgeon is insisting on mediastinoscopy. Chakor, you agree for mediastinal staging before the surgery?
Yes, sir. I'll go for that because there is possibility of finding a mediastinal node positive on EBUS, and so it will be better to do a mediastinal staging.
Okay. Next slide. I think the same slide. Yeah. So this is what the NCCN 2021 guideline says. That of course we have to look at the lung function tests, pulmonary function tests, because you are removing a part of the lung. So it should be an adequate residual lung function after the surgery. And the pathologic mediastinal lymph node evaluation is sort of recommended here, as you can see. And brain MRI with contrast, say for stage 2 and 3A, and optional for stage 1B. So that is the current guideline. Next slide. Can I have the next slide, please? Okay, so these are the clinical assessment, pre-treatment evaluation. Again, depending upon, if it's an early stage, as we saw before, one can, skip the MRI, I guess, if the PET CT is okay. But you need the mediastinal staging, which is quite critical, for these patients. Next slide, please. Okay, so Dr. Priya, for T1 peripheral lesions, can we skip the mediastinal staging?
Yes, sir. T1, definitely T1A, at least A and B, yes.
Okay, so you said you wanted to do mediastinoscopy.
Anything more than 1 centimeter. We would prefer so T1 is the only lesion where in peripheral T1 is the only sort of lesions where we can skip mediastinal staging. If we see the PET CT, it was only mentioned early stage. The size was not mentioned. So if I consider anything more than T1, I would definitely go ahead and do a mediastinal staging. Only a peripheral T1 N0 on PET, I would probably skip it.
Right. So I think this is about 3 centimeter tumor, and it is little on the periphery, but then I think this would call for.
Yeah.
So what is the best procedure for mediastinal staging to such patients?
So from our angle, EBUS has been shown to do quite well. The values have improved, the yield has improved for a lot of pulmonologists now with the learning curve. So yes, the first stage is only EBUS. If EBUS gets us enough samples, then we would not need anything else.
So what about the difficult stations for EBUS? Do you have any specific, criteria to decide that this patient should also undergo a mediastinoscopy before the surgery is performed?
No, sometimes we do advise an EBUS with the EUS, but
Correct.
not always a mediastinoscopy.
So by and large, what I understand is that mediastinoscopy is quite, I mean, it's not done very frequently these days, right?
It is kept in the back of the list, sir, because EBUS is much less invasive, much less of a risky procedure. Patient tolerates them much better. So mediastinoscopy is definitely done at institutes, but less commonly than EBUS now, sir.
So if you have 100 patients of, stage 2 or maximum 3A, so what percentage would go for mediastinoscopy
Hardly
out of 100?
15 to 18%, I think, sir.
Okay, 15%, still 15%.
Yes.
So any thoughts from the medical oncologist on staging in the for the mediastinum, Dr. Kaushal?
It's the same. We also advise the EBUS guided mediastinal staging in our routine practice.
Ashish, any thoughts there?
Yeah, so the bottom line is that we do not want a futile thoracotomy for a patient. So we have to, as we have to do everything possible before we take the patient for a surgery, that this should not be a multistation N2 or an N3 disease, which we missed based on, because we know that the sensitivity of whatever we do, the reach, everything there are limitations. So if you do a surgery for somebody who has multistation N2 or N3, then that patient doesn't do well and he doesn't benefit from the surgery at all. So that's the bottom line. And we use all the expertise available at your center. And especially the PET is a good thing to do upfront because it tells you where to put your needle. The needle will be EBUS guided or mediastinoscopy or CT guided, that we can decide in an MDT, and then take the discussion from there.
Yeah. So Dr. Priya, if the patient has a 3 centimeter lesion and the PET CT does not show any lymph node, would you still ask an EBUS or you would go for surgery?
So 3 centimeter would say T1C, right, sir?
Yeah.
No, probably 3 centimeter would be a borderline. You're putting me in a fix here.
That is what we want to learn, I mean, so, okay, I mean, let me say 3.5 or 4 centimeters.
Then I would definitely do it.
3 centimeter, I'm sorry to have, put
me
you
in a
in the spot. I didn't mean that.
No, sir. Means if I'm on the conservative side, I would probably still do it. But if it's a T1B, definitely I'll skip it. T1C is like I'll see how the patient is overall, the general condition, and individualize it and put it forth in my MDT also. Like definitely Dr. Ashish said that also helps a lot in all decision making. So if I have such a patient, I'll probably also put it in the tumor board and see where the consensus for that particular patient goes.
Great. So these are, important takeaways for all of us, that where we must go for EBUS and where maybe we can discuss it in the tumor board, whether we want to go ahead with the EBUS or skip it, depending upon the size of the tumor and what we are seeing on the PET CT scan. So can we go to the next slide, please? Okay, so I think this patient did not, they couldn't locate a node in the mediastinum and underwent surgery. Next. Yeah, so here I think they did see node positivity, and the size of the tumor is 2.9, 2.5 into 2.0 centimeter without any visceral pleural invasion and no lymphovascular invasion. So, but the node is positive, I think 2 nodes are positive out of several resected. So another question to Dr. Priya. So like you see in, colon cancer or in maybe even stomach cancer, so is the adequacy of surgery judged by the number of nodes removed?
Yeah, routinely we count around 12, but is a criteria is around 12. But we have seen a lot of times post chemotherapy, the yield becomes less if the patient is coming up after a new adjuvant chemotherapy. But 12 to 15 is a guideline for node mediastinal lymph node dissection, sir.
So, Dr. Kaushal, do you routinely see so many nodes removed, in lung cancer patients in your clinic or in your hospital?
No, in my practice, I'm not seeing, sir. In my center, I think.
So, how many
Very
nodes?
few only with this thing, 12 to 15 node. Otherwise, very few nodes they are removing.
Dr.
I have
Chakor?
not seen too much yet at my center.
Yeah. Dr. Chakor?
So not frequently. So few times, yes.
So mostly it is 3, 4, 5?
5, yes. Up to 5, 6.
Dr. Ashish?
Yes, sir. I think it also depends on the location, and if I mean most surgeons, if the nodes are enlarged, they go after it and they remove it. And
Right.
systematically doing mediastinal lymph node dissection in pathologically normal appearing nodes. I mean, I'm not sure if there is a standard guidelines anywhere, but any abnormal node should be sampled. And I think here for this patient, the station 10 and 11 may be just regional nodes, and these are microscopic deposits which no imaging would have picked up.
Right. So, Dr. Priya, why is it that surgeons are, it's not casting any aspersions on anybody. So, as Kaushal said and as Chakor said, people are only seeing 5, 4 nodes,
Sir, actually, like I think what Dr. Ashish said, that a lot of people think that sampling is adequate, but for normally an onco surgeon, the principle is not, I mean, it's not yet proved to be sampling. So a systematic lymph node dissection depending on the lobe, yes. So right side we do take 2, 3, 4, and we'll take 8 onwards, and similarly on the left side we'll take 5, 6. But yet if a surgeon has done a systematic lymph node dissection from as per the lobe defined, the yield is guidelines say should be around 12 plus. So in my institute with the team I work with, on an average I see 50 to 16 nodes minimum harvested in each patient, positive or
Great.
negative.
So, I think I'm sure there are a lot of medical and maybe radiation and maybe, I don't know, if surgical oncologists are listening. So, I think it's an important take home that we discuss and go back home with our surgeons. Because in colon and in stomach we've all passed on this message, and there's a lot of discussion on the number of nodes which should be removed in a patient with non-small cell lung cancer when the patient is being operated. So I think it's an important take home to my mind, because no treatment can replace the surgery or surgical removal. So even if you're doing chemo or target or radiation, if at all, surgery is so very critical. Adequate surgery is so very critical in a patient with early stage lung cancer. So, can we go to the next slide, please? Okay. The question is regarding the reflex molecular testing. So, is it done as a reflex when the sample goes there, or you need a prescription from the surgeon or from the medical oncologist? So, Dr. Priya, what is at your place?
Yes, sir. At my center, we routinely do molecular testing of the resected sample more for academic reasons also. But a form is duly asked from the surgical oncologist, and molecular testing is done at our center.
Okay, Dr. Kalra, please.
Yes, sir. They are not sending. We have to prescribe this thing, molecular testing. They are not doing routinely.
So the medical oncologist, the patient is referred to medical oncologist, and then Dr. Chakor.
Yes, sir. So here also the pathologists don't do it reflexly, and we request, and then it is done.
And Dr. Ashish, please.
Yes, sir. We have to request the pathologist, because there are payments
We have
involved,
only
and
5 minutes
and
left.
nowadays there are too many tests, so they need to know what to do.
Okay, so I think the practice is to go through the medical oncologist. Next slide. I think we are short of time, so I think we don't have a pathologist. I think we are. Next slide, please. We can rush through a few more slides. So I think this is. So I think we have covered this part, and I think Dr. Kalra, what is the methodology? Is it the NGS, or is it the PCR? You go once. How do you do the testing these days?
So NGS.
NGS.
We'll go for NGS only. Yeah.
Dr. Chakor.
So, sir, for adjuvant, for such a setting, I'll prefer PCR, because the data is mainly for EGFR. So even PCR is okay. So
Okay. Yeah. Right.
I
Right.
is good.
Correct.
So actually, everything they have to see is my point. I'll cross also we have to see if there is a we have to start a durvalumab. We have to rule out this EGFR, AL cross, these mutations also, because we have seen this in durvalumab. If these mutations are there, durvalumab won't benefit. That's why I will go for this.
So durvalumab is only for patients who are undergoing CTRT. Here there is a resected patient where all disease has been removed. So such a patient may not be suitable for durvalumab. But anyway, the question is, this patient is stage 2 adeno-CA and is EGFR mutation positive. So Chakor, is there a role for adjuvant chemo or osimertinib with or without chemo?
So, sir, the data is pretty good for osimertinib, and so we can just start with osimertinib in such a patient.
Okay, so no chemo. No chemo?
We can skip the chemo.
You can skip the chemo. Dr. Kaushal?
Sir, I will give chemo followed by this thing, maintenance osimertinib.
Right. Ashish, Dr. Ashish, please.
Sir, we are running short of time. A
We
minute,
need this last question. Dr. Ashish, please. This is an important one.
So chemotherapy, yeah, is node positive. So node positive patients in my practice, all of them get chemotherapy, at least 4 cycles. And yeah, that's...
Followed by osimertinib if the patient can afford.
Yes, sir, definitely ADAURA data has to be discussed. We can't ignore it with such big separation of the curves. And I will be happy to see the OS data also. In a couple of years, we should have that.
So my final question to the 3 medical oncologists, if the tumor is only 2 centimeters and there is no node involvement, so it's even earlier than that. So Ashish, will you give chemo or only osimertinib, or what would you do?
So yes, sir, I mean, that is a tricky thing. In an ADAURA trial, I think the inclusion criteria was 1B and above.
1B,
So
yeah.
yes, sir. So that is, but again, the benefit is more if the risk is more. So for smaller size patients, but this is lung cancer, it's not breast cancer. Even with a small node negative, the relapse rates are pretty high, 40-50% sometimes.
Osimertinib, yes or no? Chemo, yes or no?
Chemotherapy, yes, if the patient is fit.
2 centimeter tumor, node negative. And in the ADAURA study, there were 60% patients who did not get chemo.
Yeah. So yeah, I mean, the Anita and those meta-analysis would tell me that not to give for such small tumors. Yes, sir.
Chemo, so only osimertinib,
Yes,
right?
sir.
Yeah, Dr. Kaushal, 2 centimeter node negative.
No, sir, actually, after 2A only, we'll give adjuvant chemotherapy. In 1B also is doubtful, so I will not give.
So osimertinib you will give?
Osimertinib, sir, the tricky thing, I think we should give. Benefit out, we should give.
Okay,
Otherwise,
I see. Chakor, what do you think?
I agree with both of them, sir. Just osimertinib alone. So,
Okay, so I think small tumor, not fit for chemo, less than 4 centimeter, osimertinib alone would be a choice. So I think we tried to cover a few things here in this panel discussion. So I'm thankful to the organizers. Thanks to Priya, Kaushal, Ashish and Dr. Chakor for the interactive session. Thank you very much.
Thank you so much, sir. It was good fun.
Thank you, sir.